Hi guys, good evening and welcome to these deliberations in Obs and Gynae. We are now discussing the MCI exam which you guys just gave yesterday. And looking at the Gynae paper, I'm so happy that I'm sure that all of you got these correct. I've got around 25 odd questions. I'm sure there were a few more. And I'm also sure that there might be a little bit of overlap between Gynae and some PSM. But more or less, I'm sure Gynae would have pulled, this Gynae paper would have given you the confidence that you've read well for exams because they've asked you good questions and dare I say they've asked you easy questions also. So I'm sure you must have got the confidence that you've done your exam well. I hope the other 18 subjects also were just as good. So let's start right away with the questions. And there's a disclaimer that these questions are recall based and motive of this session is to get the actual questions and which were asked in the exam so that we can correct those get the proper questions and give you the best answers possible. So far, let's have a quick recall of what you guys saw and what you guys wrote and whether it was correct or incorrect. Right, guys, let's start immediately. So identify the device shown in the image below. I think the easiest question in this whole exam. I mean, if you got this question, was there some other question regarding this? Because I think this was a sitter. They wanted to give you 1 mark immediately. So was there some other question regarding this? Hi, everybody. Whoever is saying hi. And was there some other question asked about this? Yeah, it is the Lippi's loop. I mean, that's the easiest thing which I said. I'm sure nobody has got that wrong. So yes, this is the Lippi's loop. It's the inert loop, and this is one of the first generation of IUCDs. And it's based on the principle that if you put a foreign body in the uterus, it'll prevent a implantation of an embryo. So because the uterus will go on contracting on this device, and that contraction will expel an embryo whenever it comes for an implantation. So I'm sure you guys got it correct. Exactly the same question. All right. So let's move on. This is a very, I'm sure there are some other sessions also. So let's quickly do the easy questions at least. Till when can a intrauterine device be safely inserted in a postpartum female? Right. This is an interesting question because PPICD, in every class, I've been telling you that this is the new method which is being used by the government of India. It's not very new anymore. It's more than almost 10 years now that this has been in practice, and there are very good guidelines regarding that. So I hope all of you got the answer correct, but it's a little tough one. Immediate postpartum, we can insert it, but how long immediate postpartum you can do it? So for the definition of PPIUCD, we're asking for the purpose of PPIUCD. So for that purpose, what did you guys write? 6 weeks, 7 days was also there. Okay, let's write 7 days here. Okay. Choice E, if at all it was in the option. Yes, so tell me guys, what else did you get? I want to know what you guys wrote. I want to see some answers. 24, 7 days. There's a 48 also, 6 weeks also. So guys, this is a very, this is a new information. I'm sure that a lot of you must have not read about this. PPICD is the one which can be put into the uterus immediately after delivery. You take out the placenta and put it. You can also do it after a cesarean delivery. You do a cesarean, and while when you're about to close the uterus, you can insert a PPICD during a cesarean also. And you can do this PPICD that suppose a woman is delivered today, then how long can you put a postpartum ICD? You can do it up to 48 hours. Don't say 6 weeks. Postpartum is 6 weeks. So if you put it after 6 weeks, so, I'm so sorry. Puerperium is 6 weeks. Puerperium is 6 weeks, correct? But PPICD is not till 6 weeks, okay? So if you put an IUCD after 6 weeks, yes, that is the best IUCD retention rate, and that is the best time to put an IUCD. All of that we know. But if you put an IUCD immediately after delivery, this PPIUCD, the expulsion rate is 12%. So we know that the best IUCD retention is after 6 weeks of delivery, but they have not asked you that question. They've asked you, how long can you put a postpartum IUCD or post-placental IUCD? So when you're trying to say post-placental IUCD, after removal of placenta, how long can you do this? So that can be done for 48 hours. So if some other answer has been given to you, then that is wrong. Okay, so here it is post-placental IUCD 48 hours. That's the answer to this question. So I'm just showing you the ICD reference manual for medical officers and nursing personnel from the Government of India. And here they've told you very clearly, postpartum women who breastfeed the infant can also have a copper ICD safely inserted, as it does not interfere with the breastfeeding. But that is after 6 weeks is the best time. Now, postpartum IUCD can be inserted immediately after vaginal delivery or during cesarean section up to 48 hours after birth, before women get discharged from the health facilities. Okay, so this is for your reference, and that's a very good manual which is available online for all of you to read. It's got a lot of information about IUCDs, not just regarding the post-placental IUCD, about the IUCD in general, and what are the complications, what are the management of these complications. A very good reference manual. And since your PSM people are teaching about this, I'm sure they're referring to this and teaching you. You must also have, you just download this whenever you're reading for a NEET exam next, right, guys? Sorry. Copper T380 here means what? What is your doubt? I don't know. It's not written here. If it comes here, then we'll discuss. That is not there in this question, my friend. Mahesh Shavani, Swami, rather. So, yeah, Ahmed is saying don't disturb. So it doesn't matter. We'll come to 380. 380 is Paragard, okay? That is the name of the IUCD. The Paragard is 380A. All right, let's move on. So a 32-year-old woman who presents with intermenstrual bleeding after the insertion of a intrauterine device. She has no other complaints. What is the next best step in management? So a woman had an IUCD inserted. The question would have been a little bit more specific. They would have asked you when was the bleeding, whether it is in the month where the IUCD was inserted, which I think would have been the question. Or was it after 6 months? Or was it after 1 year of application of the IUCD? I'm sure they would have given more details about this question. More or less, I'm very sure they're asking you, what will you do when you've inserted an IUCD in the next 1 or 2 months? She's having intermenstrual bleeding. This is what generally is a symptom of a lot of women who come to us after an IUCD. So that's what they would have asked you. They're going to ask you outright simple questions. And that's what has happened in this exam. They've asked you core basics. And I keep telling you, please don't read big journals and don't read online references. Don't get latest guidelines. They are asking you core basics. And this exam is a very good demonstration of what I've been teaching you on the PrepLadder forum and also in the live classes wherever you guys have met me. So yes, so 1.5, there was no bleeding, there was spotting, reassurance. Yes. So when a woman is having intermenstrual bleeding, all we have to do in the first 2-3 months, there might be some intermenstrual bleeding. So reassure the patient and observe. But yes, if it is excessive bleeding, then we have to think in terms of, other problems, like maybe there could be an infection. Infections will increase the bleeding. So we'll do endometrial swabs and we'll do cultures and see what else is wrong. Even if there's an infection, we don't remove. We first treat the infection and see if the patient is fine. So very important, if a patient has infection, don't put an IUCD. But you put an IUCD and she's having some infection, try to take care of the infection. It's not, the first thing is not you always take out the IUCD. A lot of women will get all right with the antibiotics which you give specific to the cultures which grow. So this woman is having intermenstrual bleeding, and if it is within the first 2-3 months, don't bother to do a very severe treatment. Just see if it is spotting, especially somebody saying if it is spotting, I'm even more reassured that you don't have to do anything. So I'm reassured. So that's why I go ahead and reassure the patient. All right. What else are you guys saying? Transvaginal sonography. Yeah, it is there. Pelvic ultrasound is there. So yes, you can do an ultrasound. But what is the ultimate management? You're going to reassure even after the ultrasound because nothing is going to come out of this. So yes, go ahead and reassure the patient. Okay. Right. So this also I'm giving from the same manual. If the bleeding is mild and within less than 3 months of insertion and there is no evidence of pathology or pregnancy, then reassure the client and give iron folic acid for a month because she bled a little bit, give an iron folic acid per month. But if it is heavy bleeding and if it is twice as long, like than periods and twice as heavy, then you can think in terms of referring to a gynecologist who will take care of the bleeding like you generally do for abnormal uterine bleeding. Okay. Nitish Chaudhary, you're asking me some other question. If we don't see the thread PV, can we suggest X-ray? Yes, of course. You can suggest an X-ray. You can do an ultrasound. All of that is for a missing IUCD. That was not asked here. Okay, so your query is correct, and I mean you're asking about something which is not related to the question as of now. So let's move on and see anything else, you guys. Okay, fine. So a lady with previous lower segment cesarean section now presents with an occipital posterior position. What is the next best management? OP. MCI students, remember every class I've met you in live sessions, and wherever I've taken the PrepLadder forum, either it's on the MCQs or the PrepLadder class, I've told you, please read occipital posterior. That one mal position they're asking you very regularly. So most common position is left occipital transverse, and the most common mal position is right occipital posterior. And they've asked you which pelvis the rotation is possible, which pelvis rotation is not possible. And we've told you in occipital posterior, there is infraumbilical flattening of the abdomen. All of these questions have come. And now they've asked you another question. If there is a previous LACS, will you be able to give a trial of normal vaginal delivery if it is an occipital posterior? So what have you guys written? A, attempt normal vaginal delivery. Extensocephalic version is not the answer, obviously. So perform a cesarean section and between A and B, a normal vaginal delivery or a cesarean section. Of course, vacuum assisted delivery, if you have to do a vacuum, that can be done in the second stage. That's a different thing. So obviously, both of these is not the answers. Between A and B, what are you going to say? Definitely, I'm going to say, go ahead and attempt a normal vaginal delivery. Occipital posterior. This is a favorite AIMS question also. When it was AIMS, now, of course, it is INI-CET. So whenever they ask you about occipital posterior, what is the management of occipital posterior in labor? Wait and watch is what we used to say, because mostly occipital posterior will deliver. Okay, it will become occipital anterior 80% and deliver. It will stay occipital posterior in 15 to 16%, and then also it will deliver. So yes, in a previous analysis also you can give a trial of normal vaginal delivery. Okay. There was an option of TVOC. Anyway, the answer is definitely here that you can go ahead and do a normal vaginal delivery. Let's quickly go to the next question. What is the most common cancer of females in India? Sitter. I mean, anybody wrote this wrong, then I'm very surprised if you got this wrong, because this is what is told by every teacher of surgery and gynae. We are always discussing this MCQ. Yes. You all said breast cancer, correct. And I don't know whether they asked this question or they asked most common genital cancer. So if it was genital cancer, it is cervix. Overall, what is the most common cancer? It is breast cancer. Overall, what is the most common tumor of women? So yes, be careful. Most common cancer of women, most common genital cancer of women, and most common tumor of women. If they ask you this question, which has not come for a while, then that is a fibroid, because tumors are benign and malignant both. So if they ask you most common tumor, then benign and malignant all put together in women all over the world, fibroids are the most common. Okay. Chalo, that's an easy one. Next, go to the next question. A 28-year-old para 1 live 1 presents with intermenstrual bleeding for the past 1.5 months. What is the first investigation performed? So this 1.5 month came in this question. 1.5 month or 1.5 month, I'm sure they're asking. So what is the first line management? If a woman who is sexually active, she has one child, she's sexually active now, and she's got intermenstrual bleeding. Yes. What do you think of any woman who is having abnormal bleeding? Yes, you will do some investigations. So what is the first thing you're going to do? Of course, you're going to do a general physical examination and rule out any local lesions, which is the cause. It could be some, vaginitis, vulvitis, or it could be a postcoital tear. So if there is no local lesion, then what is the first thing you're going to do? Very important question. What is the first thing you're going to do if after local examination you don't say anything wrong? Now, somebody's saying most common gynecological cancer. Then answer is CS cervix. So let's not go to the previous question too much. I have anyway clarified all of that. So it was most common cancer, go for breast. If it is most common genital cancer or gynecological cancer, go and say CA cervix. So this one is sorted out. Okay. That's a simple question. Now answer this question. If a woman is having intermenstrual bleeding, what are you going to do? Yes. So first is ultrasound. Somebody is saying one option was pap smear. Look, whenever there is a bleeding, you'll examine first. And if there is no local lesion, then for the cervix, you do a you'll have a more specific history. So I'm not getting into all of that. They'll become a very long discussion. Just hold on for the time being. Just take this question. A woman is having some irregular bleeding. She's sexually active, and there is some intermenstrual bleeding or spotting. What are you going to do first? So yes, we do an ultrasound, correct. But before that, we rule out whether there is a pregnancy test positive or not. Because when we're doing an ultrasound, we know on the back of your head that the HCG is positive. So we are looking for a pregnancy related cause. And if the HCG is negative, then we know that this patient could be having so many other causes of vaginal bleeding. So we are looking for those. So if we know that she's pregnant, then we're looking for pregnancy related causes first. So always before the ultrasound also, you should know whether she's pregnant or not. So go ahead, those who wrote rule out pregnancy and wrote urine pregnancy test, that's the best answer for this MCQ. So because when we do the ultrasound, we should know whether she's having HCG positive or not, because HCG is positive and it's a level which is less than 1500, we won't see a gestational sac, whether it's in the uterus or the ectopic. If it is more than 1500, then on a TVS, we can see a gestation sac in the uterus or in the ectopic. So pregnancy-related cause you can rule out. Now, if she's not pregnant, then we'll look for endometritis, if there is endometrial thickening, which is too much, or whether there is a fibroid or there's a polyp. All those things we can make out by an ultrasound. So yes, an ultrasound is to be done, definitely. But first thing, you should know whether she's pregnant or she's not pregnant. So that's why the best answer here is do a pregnancy test first. All right, let's move on to the next one. A woman who is 17 weeks pregnant presents with hypertension. That's an interesting question. Please correct me immediately if it was not 17 and it was 27. So if it is 17 weeks and she's having hypertension, blood pressure was 140/94. And after 4 hours, they checked the blood pressure again, just in case she was scared of the doctor and her blood pressure got a little high. So we keep her in an observation room and put her, ask her to lie down and relax. And then we check her blood pressure after some more time. And after 4 hours, 6 hours, the blood pressure is again 144/90. That means it is still the same. What is the most likely diagnosis? So yes, if it is before 20 weeks, yes, anybody saying 17 weeks hi tha? Okay, if it is 70 weeks, then it is definitely a case of chronic hypertension, okay? Because gestational hypertension by definition, please don't go and see what is written in latest evidence and updates coming in the Royal College or the American College. I don't want you guys to get into any of that. You should know core definitions. Before 20 weeks, blood pressure is high. It is chronic hypertension, which is presented in pregnancy. After 20 weeks, if the blood pressure is high for the first time, it is gestational hypertension. So no confusion on that. Now, a woman is a hypertensive before she got pregnant. She was a 19-year-old girl. She had hypertension. Now she's 29. She's got pregnant. Her BP is high in the first trimester of pregnancy. It's again chronic hypertension. During her pregnancy, after 20 weeks, her blood pressure increased even more. And she started having proteinuria. That is acute on chronic hypertension. So there's no evidence in this question of acute on chronic. So there is only one answer to this one, and that is chronic hypertension. So I hope all of you got that correct. No, it's not preeclampsia. I'm so sorry. So the option was not only chronic in preeclampsia with chronic. No, in preeclampsia, there could be an option that it is superimposed preeclampsia on a chronic hypertension, which is acute on chronic, which basically means acute on chronic. That's what I explained to you just now, my friend. So BP was way more than this value. That's all right. It's all right. See, at 17, you won't say acute on chronic. Acute on chronic only is defined after 20 weeks. So you cannot say acute on chronic before 20 weeks. Go by core definitions, my friends. Don't get confused. Blood pressure high before 20 weeks in pregnancy, it is chronic hypertension. After 20 weeks, it is gestational hypertension, or it may become preeclampsia if it is proteinuria. And if there's a blood pressure which was high from beginning of the pregnancy and increases after 20 weeks, associated with proteinuria, low platelets, then we say acute on chronic. So this is not acute on chronic, and please don't say that. At 17 weeks, we can't say that, okay? Core definitions, bar bol raha hu. Don't think of what is given in some fancy updates from Australia, New Zealand journal, or it has come from some American journal. I don't want any of you to get into BMJ and give me a latest call on the new guidelines. Please don't do that. Okay, go to core definitions. Right. Okay, let's move on. Early cord clamping is performed in which of the following scenarios? So indication of early cord clamping. So we should all do delayed cord clamping, and delayed cord clamping is how many seconds? More than 60 seconds. At least we should wait so that the hemoglobin of the baby increases. That's clear. Now, where you should not do it, classical MCQ hai, and I'm sure all of you marked the correct answer. Come on, tell me, guys. RH negative. So this is straight away RH negative. You will not do delayed cord clamping. But there's another choice here which says eclamptic patient. That is, I mean, whether she's having eclampsia right now. Okay, if she's convulsing right now, then also I will not do a delayed cord clamping if she's convulsing right now. So yes, if she has pre-eclampsia, then it would have been easier. Now, eclampsia and RH negative, again, I will definitely go ahead and mark this. This is what they wanted you to know. That choice maybe is not properly recalled by the student who's given us this. So I'm sure it would have been pre-eclampsia and not eclampsia. But even if it is eclampsia, the present moment she's not convulsing, I can still wait for 1 minute. It's all right. Okay. So answer is RH negative. That's a simple question. Let's move on. What is the recommended approach to manage nausea and vomiting in pregnancy? Good question. Yes. I want to know the choices. Was it domperidone or doxylamine? Okay. Doxylamine. Was this the choice? Because that is the approved drug for management of vomiting in pregnancy. Look, domperidone and metclopramide, all of these are good drugs and they are not harmful to the baby. Let me reassure you that they are category B drugs and they are safe drugs in pregnancy. But the problem is that they have extrapyramidal side effects. So better tolerated and good results is by doxylamine. But was domperidone given as the choice? Domperidone was given as a choice. Okay, so what did you answer? Did you answer domperidone or you eat frequent small meals? So look, when a patient has nausea and vomiting and she's come to you to the hospital, you will always give a dietary advice. Give frequent small feeds. Don't eat a bulk meal because everything is a little bit slow in pregnancy. You may digest a little slowly. Your biliary stasis is also there a little bit. So eat frequent small feeds. That is a very good information to give to all pregnant women. But that's not the best. Always give the drug for the management. So the drug in all of this, I will definitely answer B as the option. And along with that, I'll give you the dietary advice. But that's why A is not the best answer. B is definitely the best answer. Okay. So yes, any pregnant woman, we always say that if you eat too much, you may digest a little slower. You may get a little bit of reflux and you may not be able to digest it too well. And you may puke a little bit. So frequent small feeds is very good in pregnancy. We always say, rather than 3 major meals, have 6 small meals. This is what we say. That's a routine advice you give in pregnancy. But even if she's vomiting, first thing we'll treat the problem with a drug. So if domperidone was given, so go ahead and do this. Mahesh Swami, toast and biscuits. I'm so happy with your approach, my friend. Toast and biscuits, dry toast without butter, dry biscuits without the cashew and the butter biscuits and the butter bites. You know, the simplest biscuits, the dry biscuits. She's lying down and she eats them before she gets up, before she even brushes her teeth. That is what is the daily advice I give to my patients who are, because I generally see the early pregnancies. Once they, we treat them for the infertility, they come to me with the early pregnancy very often. So when they're vomiting, my best advice to them is we tell them, we demonstrate, keep lying down, and this is how you have to take your biscuit in the morning. You're lying down, you have not brush your teeth also. Okay, fine. While lying down, you can rinse your mouth and throw the water in a small cup or something, and then take biscuits while you're lying down and swallow them. And once you've swallowed them, then get up. So those dry biscuits will soak up the acid and will give you good relief. But these are dietary advices apart from domperidone. Okay, chalo, enough on this. A lot of you are writing, everybody giving different answers. Okay, we are not worried about that, Faisal alone, because you're talking to me, aren't you? So you're my student, and if you're talking to me, then you're going to follow this advice. Go ahead and write domperidone and don't be worried about that. All dietary advice is secondary. If a patient is vomiting, you have to treat the vomiting first. Okay, so don't worry. Only one drug, metclopramide, was mentioned. Now, see, if there is a choice like this, then it is vitamin 6. Was vitamin 6 there in the choice? Now, you guys are confusing yourself and confusing me. So, see, if there is a drug given, domperidone, in the choice, I'll go with that. If there are no drugs given, then frequent small feeds is a good answer. So decide the question and tell me, guys. If there is no drug given in this, then I told you frequent small feeds is a good management of vomiting. But if there's a drug given, we'll give the drug first and give the dietary advice. So Don't worry. If this question is a mix of two questions, if somebody is recalled to me, then fine. The separate questions, if they've been given in the exam and you said that there was no drug, if there was no drug given, then go ahead and mark frequent small feeds. Correct answer. If there's a drug given, go ahead and mark domperidone. All right. So don't get too nervous. If you've done it correct, then nobody can go and change that answer for you. So don't worry about that. Okay. A lot of people are saying domperidone was given. Somebody has marked domperidone also. So let's go ahead and see the next question. Best drug is doxylamine and paradoxin combination. This is what I wrote for you so that you don't forget this bit. What is the ideal number of antenatal visits recommended during pregnancy? Yes, SITA MCQ for OBS and gynae and also for your PSM. I'm sure all of you wrote that. And look, WHO doesn't come here. We'll ask you what are the Indian recommendations. WHO recommends a lot of things. What we follow in our hospitals is what is coming in exams. So please don't worry about what is WHO saying all the time. What we've accepted out of WHO, that is what we're going to ask you. So not everything what WHO says is immediately implemented in the Indian healthcare setup. Okay, so if WHO is writing a lot, you have a lot of free journals, free update, free books from WHO. So don't think that whatever WHO writes is immediately implemented. Not at all. Okay, we have our own healthcare ministry, and the health ministry decides what is to be followed in the medical colleges. Once the medical colleges follow, then it becomes an MCQ for you. So please do not just say it was written in the WHO manual. It is there on the WHO website. Do not fool yourselves by that. Okay. 4, I hope all of you wrote. Yes. 8 and 4 were not in the option. Shalu Tanwar, was it not in the option? If 4 was there in the answer, go ahead and mark that. Okay. All right. Solution BSc nursing. Hi. 4 to 7 was the option. 4 is not there. 4 to 7 was the option. Yeah, go ahead and mark, Kushi. If 4 to 7 was the option, look, they've not written 4, they've written 4 to 7. Then again, this is the correct one. Because at least 4. If you increase to 4 to 7, there was a choice, then go ahead and mark that. That's fine. That's a hybrid answer between WHO and the Indian setup. So not to worry. Uh, as many visits as possible is good. But ideal, at least, is 4. If you can go to 8, which WHO says is even better. And if you do 12, that is still better. So all of these are correct answers. But what is the least number? Then we say 4. Okay. Okay. So 4 to 7 is was there a choice? Then go ahead and mark that. Okay. In cases of suspected ectopic pregnancy, which of the following hormone is typically measured? अब इसमें क्या choices थे यार? I hope all of you got the choices correct. Yes. Anybody else with a different estrogen, progesterone, beta HCG, LH? Was there a inhibin? Okay, was there an inhibin here? I'm just asking you. Yeah. So yeah, HCG was there. So yes. So if HCG is there, then go ahead and mark that. Okay. If HCG is there, then go ahead and mark that. All right. What are the contraindications for the use of ventos, vacuum extraction during delivery? Yeah. When you should not be using vacuum. We have discussed that, and this is a very good MCQ. Yes. Any dilatation more than 6 centimeters, you can use vacuum. So yes, if it is more than 8 centimeters, then it is fine. It's not a contraindication. Answer is between A, B, and C. C. Preterm. Yeah, most of you wrote C. So yes, in preterm head is soft, and if you put a vacuum, then you can injure the head, and you can cause a hematoma more likely, and there can be a bigger, caput, and I mean bigger chignon formed, and that can hurt the baby. and the cephal hematoma which can form because of the vacuum. That's why we say it's better you use a safer forceps in patient who is preterm, because forceps will make a protective cage around the head. So that's why forceps is a better option than vacuum in a case of preterm babies. Okay. So yes, in preterms, we won't put a vacuum, preferably. After 36, we generally go ahead and put vacuum and forceps both. But, much preterm babies like 33, 34, and all those small heads. So then it's better we go ahead and use a forceps. Right, that's a simple question. I'm sure all of you got this correct. Duration for exclusive breastfeeding to a newborn is, was there some other options in this also? Matlab, all simple questions, you're trying to find out what else can be answer apart from the obvious right answer. So was there a different answer you want to give apart from 6 months? That is a sitter question, my friends. This is a sitter question. I hope you've not got this one wrong. Look, they're asking you simple questions. And if you're answering, you're trying to look at they're trying to ask a trick question. Isme koi trick hai? It is so simple, there must be a trick in it. So that's where you get your very easy questions wrong. So this is a simple question. You should know this. Okay, 6 months is correct. Next question. MTP for contraceptive failure can be done up to how many weeks? Now, this is what is the information which is a little away from what has been given to you. Yes, you all know that now MTPs can be done till 24 weeks. But MTP till 24 weeks is for all the other indications apart from contraceptive failure. So when there is a contraceptive failure, unfortunately, you can do only till 20 weeks. Yes, even some of our college friends, we discussed in many forums, a lot of people still say that you can do till 24 weeks. But I discussed with, I also was having a reservation regarding this answer. And I would always say 24 weeks. I accept on an online forum here, because that's what is practiced by a lot of colleges, let me tell you. But then we spoke to the people who matter. And of course, I cannot discuss that with you here. We spoke with the people who matter, and I've got to know that, yes, they're looking for this answer, 20 weeks. And that is because the guideline is pretty clear there that till 20 weeks, we can do for contraceptive failure. And after 20 weeks to 24 weeks, only if it is a severe disease in the mother, that it is detrimental for the mother to continue the pregnancy, or it's a pregnancy because of rape, or it's a pregnancy where there's an anomaly, you can do, but not for contraceptive failure. So yes, those who wrote 20 weeks, go ahead and get this mark immediately for you. Lollipop questions, Sanjay says. Okay, good. A lot of lollipop questions, my friend, not just this one. Next one. During delivery, the head was delivered, but the shoulders were stuck. What is the most likely diagnosis? Did they really ask you such a simple question? I mean, there are some 7-8 questions which are absolute sitters. I mean, you must be feeling so excited while answering this question. You must be feeling that you jaldi khatam karo yaar, we just grab all these marks and let's go ahead to the next subject, right? It must be so exciting for you to attempt this paper. What did you write, man? All of you wrote what? What did you write? All of you wrote, wrote this one, shoulder dystocia. Yes, you did. Wow, that is, I'm sure none of you got that wrong. Okay, I'm sure none of you got that wrong. So yes, go ahead and mark shoulder dystocia. Correct. That is correct. Okay. Nobody got anything wrong. Okay, yes, yes, this is a simple one. I hope nobody wrote anything else. So this is the picture which I'm showing you here. You can see the head is out and this shoulder is stuck here under the pubic symphysis. So yes, once the head is out and the shoulder is stuck because the baby is big or the baby is having an anencephaly, these are the conditions where baby is said to be stuck. So that is because the largest diameter, obviously, of the baby, the transverse diameter is the bilateral diameter, 9.5, and the next largest is the shoulder. So when the head comes out, the shoulder will come. But when the baby is a baby of a diabetic mother, or it's an anencephaly, where anencephaly, the pregnancies tend to go post-term, then again, it can be big, broad shoulders. And big, broad shoulders are the reason why there is shoulder dystocia, even in the case of anencephaly. So yes, I'm sure all of you got that correct. So next question. What are the best postcoital contraceptive method among the following options? Was this classified even more? Was there some other choices given in addition to this? Was there some other information apart from this that the patient is, was this a choice like what's the Indian guideline or what is the best method or the drug of choice? Was it more justified? Yes. What are the choices? I'm waiting for your response on that. Yes, I mean, of course, levonorgestrel is the obvious answer here. But if they said India and all, then you say levonorgestrel, because see, ulipristal acetate is an exciting new option we have now, because it's going to going to work for 5 days. So if they just ask this, then maybe ulipristal is a better answer. But yes, all of us know the drug of choice is levonorgestrel. So the obvious answer, obvious question, go ahead and mark levonorgestrel. That's the answer. I'm very sure that's the answer. But you should know that levonorgestrel is good, but it is good till 3 days. In fact, on the third day, it is not 95, 96%. It is down to 65% the efficacy. But ulipristal can work up to 5 days. So if they are just asking the drugs, then ulipristal is a better answer. But if they said if it is in India and what is the best drug given in India, drug of choice, then go ahead and mark levonorgestrel. So that's why I'm repeatedly asking you that what was the question here. The purpose of this is, it's a previous year question. It was not... Okay, fine. I mean, like, it was a simple question, then simple answer, go ahead and mark levonorgestrel. Since there was no other this question was not justified and not specified any more than this, then go ahead and mark levonorgestrel. Which of the following is the correct definition of postpartum pyrexia? Yes, postpartum pyrexia. This is a very simple question again. And if a woman has fever immediately after delivery, then it is not postpartum pyrexia, because it could be because of a cause which was present before delivery, like she had a UTI or she had a typhoid or viral or whatever, pneumonia. So if a woman delivers, let's say she delivers at 8 p.m. tonight, and tomorrow at 10 p.m. she has fever, then that is more than 24 hours. Then it becomes postpartum pyrexia. Genital tract infections, breast engorgement, generally other causes of postpartum pyrexia. So more than 100.4 degree Fahrenheit after 24 hours of delivery. So A is the best answer. And everybody got that correct. 12 hours nahi hai yaar. It is, somebody marked D. No, it is 24 hours. Postpartum is 24 hours. Postpartum pyrexia. Next question, a 26-year-old multigravid presents with no cystocele, no rectocele, but has a third degree uterine prolapse. What is the most appropriate management for the condition? 26-year-old nulligravid. She's never had any delivery. So nulliparous prolapse, what are you going to say? This, I mean, sitter question. I mean, when we discuss prolapse, we give you these basic classification. Like, we don't give you the details of the surgery, but we tell you that if it's an old woman, go ahead and do a vaginal hysterectomy, pelvic floor repair. If it's a woman who's delivered a child and she wants to have more children, go ahead and do a Fothergill or a Manchester. But if it is a nulliparous prolapse, what do you go ahead and do? I mean, like, I hope Shirodkar vaginal approach. Sanjay, I don't know what you mean by Shirodkar vaginal approach, because if we say Shirodkar has so many surgeries. I would have given you Shirodkar's modification of Fothergill or something like that. I would not just say Shirodkar, because Shirodkar surgery, if you just say there are so many surgeries by Dr. Shirodkar, he's a stalwart of vaginal surgeries, and he's a world-renowned stalwart of vaginal surgeries. So there's so many surgeries. So which surgery they asked? So don't go into those areas which I'm sure that you're not very confident about those. And it's a straightforward answer, and it is sling surgery. I hope all of you mark that. No cystocele, no rectocele, and it's a nulliparous. See, they've written nulliparous, nulligravida. She's never delivered. Nulliparous. See, they've written nulligravida. I mean, I'm sure you meant woman who's never got pregnant is never delivered also, obviously. So nulliparous, nulligravida. It's just a way of asking the same question. It's a nulliparous flaps, guys. I hope all of you wrote sling. It was with cystocele and rectocele. Now somebody says, no, it is without. Paper is too easy. Raj Tanwar, I'm so happy you felt that way, because that's what I'm feeling. So yes, this is sling surgery. Go ahead and mark that. What is the location of a Bartholin cyst? Guys, this I've asked you so many times in the class, okay? If you see the vaginal opening, and there's the clitoris here, and there's the vulva, and I've drawn this diagram. Anterior, yes, 2/3, and posterior, 1/3. Okay, so whether this choice was there or not, posterior 1/3 of the vulva or anterior 1/3. So junction between the anterior 2/3 and the posterior 1/3. So those who wrote posterior 1/3 of the vulva would get this correct. Okay, posterior 1/3 of the vagina nahi hai, posterior 1/3 of the vulva hai. So this diagram, if anybody remembers from the class, which I've taken on the online forums and also in the live forums for you guys. So I'm sure all of you got that correct. Okay. Okay, it's a junction between the anterior. This has come in exams in your NEET exam many times. So whenever I've taught in MCI, I've told you that this is a NEET question, and where is the bathing gland located? It's located here. The vaginal opening is here in the junction of the anterior two-third and the posterior one-third of the vulva. All right. So posterior one-third of vulva. I'm sure the question would have been asked in a better way, but go ahead and mark B for this, for the options which are presently in front of you. Okay, what is the menstrual cycle length? Which of the following menstrual cycle length is called abnormal? Yeah, fairly simple question, guys. Come on. Uh, Come on, guys. You know the length of the menstrual cycle is 28 plus minus 7 days. So yes, we say 21 to 35 days. Of course, some books say 24 to 35 days also. So this 35 is mostly accepted by all the books. So any period which is more than 35 days is abnormal. So this, I'm sure you marked that correctly. I mean, they can't be asking you simpler questions than this. All those of you who are reading multiple sources of obs and gynae, multiple guidebooks and multiple, online sources and solving all the MCQs in the world, my constant advice, those who are seeing this recorded after 6 months, I mean, we are talking about July 24 exam right now, but those who are reading this for the December 24 or the Jan 25 exam also, please remember, if you're seeing this in a recording, keep it simple, guys. Keep it simple. Okay. Your favorite teachers, whoever your favorite teachers, it could be any of all of us. So many of us are teaching you gynecology. Any favorite teacher, just follow his or her MCQs on the YouTube. And I'm sure this session itself, you do all the sessions for the last 5 years. This should be enough exercise to pass your exams. If you remember that basic mantra, I'm telling you, you'll pass your MCA exam without a problem. Okay. That's the kind of questions which are coming. Outright simple MCQs. Okay, chalo, let's move on. What is given to prevent neural tube defects in pregnancy? Okay, so that's again a sitter question. I'm not even taking any answers here anymore. I'm giving you the answer. Folic acid is given. Folic acid, neural tube defects. Outright basics again. This you have to know because you're going to become doctors. Ye to pata hona hi chahiye. Huh? That's why they're asking you these questions. So please, if you are repeatedly this MCQ exam is giving me the opportunity to tell you that stick with the core basics. All right, guys? Chalo. Outlet force is applied at which of the following station? So yes, +2, we give the low forceps. And +3 and below, we say outlet forceps. So when the head is on the perineum, that is +5. So what is that? Yes, again, it is the outlet forceps. Last time they asked you what is the name of the outlet forceps. Wrigley's forceps is the outlet forceps. Okay, so +2 is the low forceps. We apply the Simpsons. That's the name of the forceps, Simpsons forceps. And outlet forceps is Wrigley's, which is applied at +3, +4, +5. Anyway, they've asked you the easiest possibility that it is head is on the perineum, which is +5. It is so much below that it is on the outlet. All right. So go ahead and mark this choice D. Okay. +3 was also given. So yes, head on the perineum again is a better option. If +3 was given and head on perineum was given, then again head on perineum is even a better answer. Okay. Fine. This is a really confusing question. I think the choices are a little confusing. Anything +3 and below, you can apply outlet forceps. So if the choices were head on the perineum, go ahead and mark that. Okay. So of course, this chat of what you people are writing on this chat is saved, and what I've given answers is saved, and the prep team will go ahead and get the best possible choices, and then we'll give you even better answers. For the time being, head on the perineum is a better choice than +3. Okay. Question was different. So you can tell me the different question and give you the appropriate answer. All right, guys. Chalo. What is the most common cause of thrombocytopenia in pregnancy? New question, guys. I'm so happy. This was a PGI question long back. When PGI was a separate exam. Long back, this question was there. Yes, it's a good question, guys. Was this a question, first of all? Some people are saying head of perineum was not given. Some people saying head on perineum is given. Never mind. So we'll stick to the question which was discussed just now. Thrombocytopenia in pregnancy. Somebody saying C, HELP syndrome. Gestation thrombocytopenia was given. See, the choices which I got was ITP, thrombocytopenia, HELP syndrome, and preeclampsia. So I'm sure that gestational word would have been there. Anybody? There was no such question. Arnav Raj Pratik. No, this question has been asked to me on my WhatsApp also. So those who have my number actually send me this question in addition to my prep team getting this question. So I think this was there. Anyway, you guys are the idiopathic was given, gestation hypertension given. All right, please remember this answer is gestational thrombocytopenia. All right, so most common cause this thrombocytopenia, all of you know, is less than 150,000, less than 150,000 platelets per microliter, and almost 70 to 80% of this thrombocytopenia in pregnancy is gestation thrombocytopenia. Yes, it can be HELP syndrome, preeclampsia related syndrome. It can be ITP also, but ITP is not so common, guys. Please, ITP is not so common in pregnancy. ITP is present to the woman even before she got pregnant. So we are talking about the most common cause in gestation thrombocytopenia is that cause of thrombocytopenia. I hope all of you got that. At least some of you got it correct because it's a little bit of a new kind of question. I mean, I accept. I've not taught you this. I've not taught you this in the MCI forum. Definitely, I've not taught you this. So one or two questions will come away from what is generally coming. Okay, one question on general medicine, general surgery will come, and teaching a whole of medicine, whole of surgery. Well, that's impossible in the time, the kind of lectures which are planned. So whole of medicine, whole of surgery, of course, there will be some questions which will be out of 40 questions, there will be a couple of questions which will be new. And that's why it's a good, exciting exam to write, that we get to know new things while we're preparing, and you get to know, okay, there was a question on thrombocytopenia. So that's how we prepare for the next exam. Good. No, it's not trimester specific. Overall pregnancy, thrombocytopenia, we go ahead and say gestation thrombocytopenia. Okay. Which of the following conditions is tandem radiotherapy commonly used? Look, I told you in all the classes that they are asking CS cervix. And last time they asked you what is the chemotherapy given in CS cervix. And now they are asking the radiotherapy given in CS cervix. So please remember that CS cervix, you should know the basics at least, that chemoradiation is the best management after stage 2A2. 2A2 and later, best option is chemoradiation. So that one is such a simple question. Now, from the last 2-3 exams, they're asking you more specific questions about chemoradiation. So last time they asked you what is the chemotherapy given, all of you said yes. We learned about it that it is cisplatin. Now cisplatin based chemotherapy, how's the radiotherapy given? Yes, you can give it external and internal, but how the internal radiation is given, brachytherapy, it is given by the rods which are put into the vagina. So the rods which are put into the vagina, those rods are known as the tandems. We'll put the radioactive source in this. Okay, and then we'll put some ovoids here. There'll be some radiation ovoids. There'll be an instrument which will be like this, and this is how we go ahead and put the radiotherapy source into the uterus. So there'll be a rod into the uterus with the radiation source. There'll be ovoids here, which will take care of the parametrial areas. So that's why vagina and the parametrium. So this is tandem radiotherapy for the cervical cancer. Yes, chalo. Which of the following is the mechanism of action of inhibin? Yes, so that's also one easy question. Let's see how many of you got that correct. Yes, anybody? See, vulva was there. Anyway, tandem radiotherapy is classically for the C cervix. So FSH inhibin. All right. So yes, I'm sure all of you understood that. So FSH, is follicular stimulating hormone, and it is going to ask in the early part of the menstrual cycle, and in the mid cycle. There are two parts of the menstrual cycle where FSH is high. Initially, FSH is high to recruit the follicles. Then mid cycle, there's a small peak of FSH again. That is to maintain the estrogen secretion from the Graafian follicle. Also, there's some estrogen secretion is there from the corpus luteum. I'm sorry, I said Graafian follicle. It is mid-cycle a little bit, initial high, mid-cycle, then high again. So this one is for recruiting the follicles. This one is to recruit the follicles, and this one is to maintain the estrogen secretion from the corpus luteum. All right. So this FSH acts here. So how does the FSH work? FSH has two brothers. So two co-molecules. So activin activates the FSH, and inhibin inhibits FSH. So in the first few days, this activin mediated action of FSH is there. And around day 10, the inhibin inhibits FSH. So activin activates FSH, inhibin inhibits FSH. So the names itself, you just remember they are co-molecules of FSH. So co-molecule of FSH, activin activates FSH, inhibin inhibits FSH. Simple. Right, guys? So that's about the questions which have been recalled and given to me. I'm sure there were a few more questions which should have been overlapped into pharmacology or into PSM, but we are here to discuss them in multiple forums. We might be meeting for a quick update before the NEET exam also. So those who are preparing for FMG, those who have given the FMG and are going to need the write the NEET exam, you're definitely going to meet us before this next NEET exam. So you can ask me the questions even there. And then we'll have multiple PrepLadder forums where we are always meeting you guys. So until the next time, next MCQ exam, I'm wishing you a lot of luck with the results for this exam. And I hope you do very well with the results and all of you become interns and come and work with me. We are having a lot of work in our department. So I want all of you to come to Delhi and work with me if that is possible. All right, guys. So best luck with the results and God bless you all. Thank you.